to present a topic on adolescence, and I thank the scientific committee for giving me the liberty to choose the topic related to adolescence. So I have chosen the topic which would highlight the developmental aspects during this crucial phase of uh, individual's development, along with certain clinical aspects, especially when we work with adolescents, that as mental health professionals, all of us need to be familiar with. So I bring greetings to all of you from the Department of Child and Adolescent Psychiatry, NIMHANS, Bangalore. And these photographs are depicting our two inpatient units. On the left is the Child Psychiatry Center with 40 beds, and the right side is the Adolescent Psychiatry Center, which was commissioned in 2016 with 24 beds. So just a quick recap of the some of the basic aspects related to adolescence. Adolescence is a term that has been coined from a Latin word, which means growing up, like adultcere means growing up. So it's a developmental stage between the childhood and the adult period. So it is typically spanning the age groups of 10 to 19 years. This definition of 10 to 19 years was initially provided by the World Health Organization, though some definitions recently have extended it to 24 years. This is because the brain development in an individual doesn't stop at the 18 or 19th year of age. And neurobiological research has shown that the brain development continues till the well past the second decade. So typically till the age of 24 or 25 years. And we also come across different other terms, like, youth is one very common term. In the Indian context, the term youth is used, even the global context, it is used for the age group between 15 to 24. So this is a phase which is, as I mentioned, like it, is a very crucial transition phase between the childhood and adult periods of one's life. And there is a rapid changes that are happening during this particular period. So you can see that there are physical changes, cognitive changes, emotional changes, and social changes. And this happens over a span of 10 to 14 years. And this is a very short period of one's life, but at the same time, quick changes are happening. And it's one of the, for the person themselves, the adolescent themselves, it is a quite confusing kind of period what they're going through at that point. So some statistics before we move on to the developmental issues. So it is estimated that all over the world, like the population of adolescents is roughly about 1.2 billions, and the proportion of the adolescent population out of the total population is around 16%. Whereas in India, as per the previous census, the estimate is about 21% of India's population, that amounts to about 243 million adolescents. So most of them, they live in the rural areas. So you can see that more than 70% they live in the rural areas. And globally, across all the low and middle income countries, the population of adolescents is quite high. And out of the 1.2 billion adolescents across the world, 90% of them live in the low and middle income countries. So this particular age group has a lot of public health relevance in the sense that the successful development during this period, and if the adolescents are maintaining their health and well-being, and if that is supported by the systems, it will translate into favorable outcomes into the adulthood. So favorable outcomes in various domains like social, health, financial aspects. And any policies or initiatives that focus on the adolescence period will are set to yield very high returns, especially in terms of the health, well-being, and also the productivity that they bring into the adulthood period. So the physical changes during this period include the increase height, weight, uh, with the onset of puberty, development of the secondary sexual characteristics, and also growth spurts that happen both in boys and girls. And the biological changes, what we need to remember is may not be uniform. They can be uneven. So girls comparatively, they have these changes slightly earlier compared to the boys. And in boys, actually, the growth spurts continues at least a couple of years after that, in the girls. And from the teenagers' perspective, these kind of rapid physical changes that happen with the onset of the puberty, it's like putting a bright spotlight on the that person's body image. So we see that the variations, like some of the adolescents, they mature early, whereas some of them slightly later. So these kind of variations are quite normal in terms of the physical changes. So there are, in addition to physical changes, we see that there are a lot of psychological changes that happen during the adolescence. So adolescents are able to reason better. They're able to think more logically, and their critical thinking is better, their problem solving abilities are better, and they are less likely to be dependent on elders, and they also have intense self consciousness. There is a lot of focus on themselves, and this is the period where identity formation takes place, and they also engage in critical self evaluation. But this is also a period of vulnerability. You can see that there are a lot of positive psychological changes, but there are also certain things which predispose to vulnerability. The adolescents feel that they are very powerful, they are invincible, and they end up taking several risks. And this risk taking can be harmful at times. And we also see that adolescents, they are quite vulnerable to the low self esteem. Then the social changes during the adolescence includes being less dependent on the caregivers, especially the parents, and also formation of the peer groups. And peer groups form the important social support during this particular age. So, with this physical, social, as well as the psychological changes, there is a lot of stress that is placed on the adolescents, and many a time actually there is lack of awareness about these normative developmental changes, and there is also comparison with the peer group or the siblings, and there is uh, family understanding also about these developmental issues in the adolescence is lacking. So the family support may not be adequate, uh, and the adolescents especially have a significant preoccupation about their physical changes, and the psychological changes cause a lot of anxiety in the adolescents. So it is very important to help adolescents during these developmental transitions by educating oneself. That is, as mental health professionals, we need to educate ourselves. And in fact, we need to provide an opportunity for the caregivers also to educate themselves about the normative adolescent development and these changes in terms of the physical, social, and psychological changes that happen. And there needs to be open, healthy discussions about these changes without any judgment or criticism. And adolescents' concerns related to the developmental changes uh, has to be, given some time and space, and we need to listen to that. And age-appropriate peer interactions has to be encouraged. So during this period, there are changes in the brain also. And on this slide, you can see that uh, from the age group of 5 to the age group of 20 being depicted, wherein like the magnetic resonance image scans of the brain that has been taken during subsequent years, right from age 5 years onwards. It shows that there is changes in the gray matter and white matter areas of the brain. Uh, the with the brain maturity, actually the gray matter becomes less dense, and there are also areas of the brain where the maturity happens earlier, and especially during the adolescence and continuing into the period beyond the age of 20. So we see that the neural pruning process continuing, and also the maturation of regions in the frontal areas of the brain. So to summarize the neurological changes, mainly the maturation in the frontal areas of the brain, especially the prefrontal cortex, that is shown both in the structural as well as the functional imaging. And this area of the brain is very important for abilities like decision making, planning, impulse control, reasoning, etc. And the pruning of the synapses keeps happening around this time to help refine the neural connections and increase the efficiency of the neural networks. And during this time, there is also the development of the limbic system. There is there are the areas like amygdala, nucleus accumbens, which are involved in emotion, reward processing, risk taking, etc. And this part, that is the limbic system, which is involved in this emotional processing, uh, reward mechanisms, risk taking, etc., develops earlier compared to the prefrontal cortex. It's like an accelerator developing earlier compared to the brakes in a vehicle. So this mismatch explains the heightened emotional reactivity and risk taking behaviors in the adolescent age group. And in terms of the white matter, through a technique of diffusion tensor imaging, which is abbreviated as DTA studies, uh, one can study the white matter density in the brain, and through that it is shown that there is increased white matter density, improved connectivity compared to the childhood between the brain regions. And this connectivity between different areas of the brain enhances the attention, learning, as well as the cognitive control in adolescents. Also, the synaptic pruning, like the unused synapses are pruned and removed, and this increases, as I mentioned, the efficiency and the neural network functioning. The reward system sensitivity is also changed during this period. Like there is hyperactivation of the reward related circuits during adolescence, explaining sensitivity to peer influence, novelty, and risk taking. They constantly seek rewards or reinforcements in this process. And there are also changes in the certain areas of the brain where the emotional related regions in decision making gradually integrating the cognitive control areas over time. So these are all the changes that keep happening in the brain. And a point about the adolescents whom we see nowadays, like the Gen Z as well as the Gen Alpha adolescents, compared to earlier generations of adolescents. So this is something commonly even in the general public also. When the discussion comes up, people say that these days, no, the adolescents are quite different compared to the earlier days. Earlier generations have been quite different. So we all know that no, this is the digital era, and the current children and adolescents, they grow up with this kind of gadgets, and they get exposed to social media. They are very much in touch with the online kind of activities, and technology influences every aspect of an individual's life. It influences the socialization of adolescents, their identity formation, and also the learning. And the current generation of adolescents, actually they have high mental health awareness, and they actively seek support. In fact, this has been shown in some of the recent studies also, which were published by the UNICEF, especially immediately after the COVID pandemic, wherein like there were increased rates of anxiety, depression in adolescents, and many of the adolescents who were surveyed across the world and even in the Asian countries, including India, they had mentioned that they are actively seeking the mental health support, and they are very open discussing about the mental health. There is also increased awareness about certain socio-political issues, could be social justice, climate change, etc. And a lot of awareness about inclusivity, diversity, etc. Their learning styles has changed very much, and there is a lot of technology-based learning in addition to classroom learning. And we have all seen that during the COVID pandemic, it has started wherein the schools were closed, colleges were closed. Children had no option but to learn through the online medium. And also the online has an advantage of allowing them access information, and it helps to shape their cognitive development as well as problem solving. But also there are problems with this, like where we see the negative side of it, like wherein excessive time spent on the gadgets, and that becoming a behavioral addiction, sometimes exposure to certain inappropriate or unwanted kind of content on the online platforms, which has a harmful kind of effect on the adolescents. And we also see that in addition to in the peer group, like it's not just the people whom they regularly meet offline. So they have a large network of online kind of friends who strongly influence their values, their behavior, and how they express themselves. And so both in the real world as well as the digital spaces, this identity exploration continues for the adolescents. So we will quickly go through some of the theories of development in adolescence. So uh, several researchers have proposed theories uh, explaining the developmental changes that happen during the childhood and adolescence period. So some of the important theories have been listed here. To begin with, the Stanley Hall's biosocial theory. Stanley Hall was a pioneer who had described the adolescence as a period of storm and stress, and the biological changes that happen. So the main focus of Stanley Hall was on the uh, biological mechanisms, and especially the changes that happen around the time of puberty that um, create emotional turbulence, mood swings, and increased conflict with the parents and tendency towards the risky or impulsive behaviors. And according to this theory, actually, adolescence is seen as a inevitable biological based stage marked by instability and heightened emotional intensity. So, the psychosocial development theory given by Eric Erikson, we are all familiar with this theory. So, it's one of the uh, important theories of child development, child and adolescent development. So, in this, especially during the adolescence, they are in this particular stage of development, which is named as the identity versus role confusion stage. And during this stage, what we see is that there is engagement in identity exploration, um, increased independence. There is a lot of influence of the peer groups, lesser dependence on the parents or caregivers, experimentation with roles and appearance, and also this the two kind of things, like where at times they feel a sense of belonging and at times a feeling of being left out. So there is a kind of contrasting things that keep that are getting experienced by the adolescents. And successful resolution of the development during this stage leads to strong and stable identity of the adolescent, whereas the failure results in confusion, insecurity, difficulty making life choices. And the next stage is the cognitive development theory given by Jean Piaget. Piaget's theory, according to that, like the adolescents, they move on to the formal operation stage. In this stage, they develop the ability to think abstractly, logically, and scientifically. They can reason about hypothetical situations, and they are able to uh, consider multiple perspectives. They're able to engage in more complex problem solving compared to the children. And they also develop this particular ability of metacognition, that is thinking about their own thinking. So it's a very reflective kind of thing wherein they start analyzing their own thoughts, and which helps them form strong identities and moral judgments. So as far as the moral development is concerned, the theory given by Kohlberg, and during the stage of adolescence, typically they are said to be in the conventional level of moral reasoning. Most adolescents are at this level, and where they are able to make decisions based on social rules, expectations, and also their desire to maintain relationships or gain approval. Few adolescents actually move on to the next level, that is the post-conventional level, where the moral reasoning is guided by universal ethical principles, personal values, rather than just the authority or social norm. And the this particular development of their morality during this period allows the adolescents to think critically about the right or wrong and form their own sense of justice. So moving on to Albert Bandura's social learning theory. So Bandura places a lot of importance on the what we call the observational learning, where the adolescents they are said to observe the peer group, observe the parents, and some of the uh, you know people who in the society who they stand out. Like say this could be celebrities or certain important persons, like who are in the sports or in the arts field, or uh, there could be leaders, etc. So who like adolescents observe them closely, and they are said to model their behaviors, and through this actually they adopt their behaviors to the social norms and develop the self-efficacy. They start believing in themselves that they can succeed. So this theory very well explains the peer influence, which can be both ways. Like peer influence can be a positive peer influence, or sometimes we see that a deviant peer influence also. And the role of the what we call the role models in shaping the behavior and also shaping the self identity of the adolescents. So this theory very well explains, and also the role of the environmental feedback in shaping their adolescent behaviors as well as the decision making. So next theory is the Bronfenbrenner's ecological systems theory. So according to this theory, actually the adolescent development is influenced by multiple layers of the environment. So Bronfenbrenner mentions that there are several contextual factors that are represented as concentric circles that with the adolescent or child in the middle, and surrounding that individual actually the microsystem, mesosystem, exosystem, and the macrosystem, and the changes that happen over a time, that is a chronosystem. So the immediate kind of context like family, school, and peers are the microsystem, and also the interactions between these contexts is called as the mesosystem, whereas the broader societal influences that lie outside are the macro and the exosystem, respectively. So, moving on to Vygotsky's sociocultural theory, this theory places a lot of importance to the cultural aspects also, wherein like the social interaction is influenced by the cultural context, various cultural contexts, and this concept of zone of proximal development was given by Vygotsky, wherein like the skill repertoire of adolescents that improves over a period of time, and it is shaped gradually over a period of time through the collaborative efforts by the teachers, peers, mentors, etc. And over a period of time, slowly, they start achieving tasks or accomplishing tasks with the guidance of these people. And there is this particular concept called scaffolding, where scaffolding means uh, the adults are more knowledgeable kind of peers. They are able to provide the support and help the adolescents progress to higher levels of cognitive and problem solving ability. So these are the positive influences that happen in the adolescence because of the peers, and as well as uh, the other elders, could be teachers or other who are there part of their life and who are able to support and scaffold their development over a period of time. And lastly, this theory by Havinghurst, where the concept of developmental tasks. So it is mentioned in this theory that there are a series of developmental tasks that the adolescent has to achieve during that particular age group, and these include becoming emotionally independent from the parents, forming healthy relations with the peer group, preparing for a career, and adopting socially responsible behavior, and accepting physical changes of puberty. So these are the multiple tasks, developmental tasks, which the adolescent has to achieve during this particular period. And when they are able to achieve this age appropriate tasks, it is said that they are ready for the successful adult life. So there are several contextual factors that influence adolescent development. Those include the family environment, peer relationships, school educational context. So in the family environment, mainly the parenting style, the quality of relation between parent and the adolescent, then family structure, presence of any family stressors, and the emotional support that is available to the adolescent, and also the communication patterns. The peer relationships, mainly the quality of the relationships and the social support that peers provide to the adolescent, and the peer pressure sometimes, and even the negative things like bullying and social exclusion, and sense of belongingness to certain specific peer groups or cliques. The in the school context, the school climate that includes the adolescents feeling safe in the school environment, being connected to the school, feeling a sense of belongingness to the school, and support from the school staff, especially the teachers, and having reasonable kind of academic expectations and opportunities, and teacher-student relationships, and also opportunities for growth in the school, not just in academics but also in extracurricular activities. And sometimes there could be issues in the school context based on certain socioeconomic kind of disparities. So that also can influence the adolescent development. And we see that life events, especially the adverse childhood experiences, which mainly could be family dysfunction or any loss experience in the form of any life events, or it could be serious kind of trauma like abuse, neglect, etc. They influence the development of the adolescent. And even the community factors, the supports that are available for the development of adolescents in the community, the cohesion in the community. And sometimes we see that the negative aspects in the community, lack of cohesion, lack of community support, and poverty, increased crime levels in the neighborhood, etc. So these may be the negative factors. So each of these contextual factors can play out as either positive factors or negative factors, impacting the development of the adolescent either positively or negatively. And the socioeconomic status also plays a very important role. The parental education, occupation, the family income, the stability of that family in terms of the financial aspects, and access to healthcare, nutrition, technology, enrichment activities. The families, what benefits they get as social welfare benefits from the government, etc. And of course, the physical health factors in terms of nutrition, sleep, even the genetic factors, no, they influence the development. The cultural and ethnic background, and more importantly, in the recent times, we have seen that the media and technology kind of impact on the adolescent development. So, moving on to the relationship between the development and mental health. So, on one hand, there is a development of the adolescents that is happening, and also the mental health of the adolescents that is equally important. These are quite closely interconnected, and there is a bidirectional influence between the development and mental health. So, development, if it progresses smoothly and without any negative kind of issues, then it's likely that the adolescent's mental health also is uh, maintained well. And developmental changes increase the vulnerability and opportunity during this period. And contextual factors affect both the development and mental health. So these two things are broadly affected by the contextual factors. The mental health itself can affect the developmental outcomes. And developmental changes sometimes can mask or mimic the signs of mental illness. And we see that social and emotional development is a vital component of mental health. So we see that many a time the adolescents develop mental health problems, and there are a lot of challenges addressing that, like because especially in our recent phase, through the normative development, people may just find it difficult to distinguish that the psychopathology from that of the developmental changes. So psychopathology is more likely to cause significant functional impairment. Psychopathology is definitely likely to be sustained over a period of time, and also, it is very important to tease out the psychopathology from the developmental changes and do careful evaluation. So we see that another challenge is the lack of awareness about these issues and lack of adequate trained mental health professionals, dedicated adolescent mental health services being limited. Uh, then the parents and teachers themselves may dismiss these problems as merely reflecting the adolescent turmoil. And there is significant stigma in the caregivers as well as the adolescents themselves. A lot of concerns about confidentiality and lack of privacy also prevent them from seeking prompt help for the mental health problems. So, the common psychiatric disorders that are observed in this particular age group include anxiety disorders, especially social phobia, agoraphobia, OCD, then depressive disorders, adjustment disorders, conduct disorder, substance use disorders, especially tobacco, alcohol, cannabis, and solvents, early onset bipolar affective disorder, early onset schizophrenia, and eating disorders. So, these are the common disorders that we come across in the adolescent age group. And the prevalence of these conditions in various studies globally, it is mentioned that rates approximately of about 14 to 15% have been mentioned in some of the recent studies. Whereas in the Indian context, the National Mental Health Survey, which was conducted in 2016, across this adolescent part was carried out across 4 states: Uttar Pradesh, Jharkhand, Tamil Nadu, and Gujarat. And in that, it showed a prevalence of 7.3%. The current National Mental Health Survey 2, that is NMHS 2, that is ongoing, and the prevalence data is expected in the coming year. And so that is awaited. Actually, it will give a clearer picture, not just across these 4 states. It is being carried out across uh, uh, all the states and union territories in the country. So with that, we will have more realistic kind of picture with regards to the mental health morbidity of adolescents in the country. And a word about the comorbid aspect. So the comorbid conditions are quite common. The scenarios are quite common in the adolescents. So it's two broad scenarios we can see. One scenario is that the comorbidity between neurodevelopmental disorders and psychiatric disorders. For example, a child with intellectual disability may develop a mood disorder, or a child with autism spectrum disorder may develop a psychosis, or a child with ADHD may develop a anxiety disorder. So sometimes we see that there are no neurodevelopmental conditions in the adolescent, but it's just comorbidity between psychiatric disorders. So OCD and depression occurring together, or it's OCD with social anxiety disorder, etc. So one more important thing to keep in mind is the transdiagnostic approach that is needed to the phenomenology, because there are certain phenomena which occur across the diagnostic kind of labels. Uh, to give an example, irritability. So the irritability is seen in adolescents with mood disorder, like both depression as well as bipolar affective disorder. Then it can be seen in adolescents with ADHD. It can be seen in adolescents with oppositional defiant disorder, conduct disorder, etc. So just based on the irritability, we can't immediately say that this adolescent has only mood disorders. So the subsyndromal, compared to the adults, actually it's likely that subsyndromal presentations are more likely, and oftentimes the diagnosis is unclear. And even when the comorbid conditions are there, it may present more like a subsyndromal presentation. When more than one disorder is occurring in the adolescents, there is likely to be more functional impairment and higher likelihood that we use the medication. And also, careful monitoring for the adverse effects is very much needed in those cases. And when more than one condition happens together, the prognosis also becomes guarded. So it is very important to identify the mental early, so that early intervention can be initiated, and also better outcomes in terms of emotional, behavioral, functional outcomes can be arrived at. There is also a lesser requirement of intense psychiatric treatment like inpatient care. It is most suited for the low middle income countries like India, and it's quite cost effective. So adolescents, when they are brought for a consultation, psychiatric consultation, they have mixed feelings. You can see that they can be shy, embarrassed, worried. They can feel very inadequate, anxious. Some of them, they may feel hopeful. They may become very resistant or intimidated, etc. So it's a mixed kind of feelings. So the process of consultation itself, the adolescents want very much to show that they are much mature and they can handle things by themselves. The mental health professional must deliver information in such a way as to allow the person, that adolescent, to participate in their own care. So we need to respect their individuality, and we need to encourage them to learn as much as possible about their problem. And adolescent needs to be informed in advance about, because we see this very often in the clinical settings wherein the caregivers, without properly discussing about the consultation, they just forcibly bring the adolescent, and the adolescent becomes very uncooperative in the outpatient setting. So for consultation, actually adequate time has to be allotted, and a convenient time for the adolescent has to be planned. Uh, the forcible consultations can happen only in situations where the adolescent has acute psychotic or acute mood kind of states, or when there is high self-harm risk, etc. Otherwise, the adolescent has to be informed, and adolescent has to voluntarily come for the consultation. So it's a good idea to meet the parents separately prior to meeting the adolescent, to obtain the history from the parents. Um, so parents are expected to bring all the relevant records, and so when we engage with the adolescents, actually we can use different activities to promote the expression. So these include actually storytelling, journaling, drawing, painting activities, playing board games, etc. So also to build the rapport, um, there are certain key elements: respect, genuineness, being non-judgmental, developmentally appropriate, use of developmentally appropriate language, use of educational material like posters, flip charts, etc. Ensuring that confidentiality and privacy are maintained, and empathizing with the adolescent, and being very honest, and providing reassurance as and when needed, and devoting time. That's also very important. Then, when we engage with adolescents, what we need to remember is that it's a process. The quality of the therapeutic engagement may wax and wane, and it requires constant attention. It's very important to speak to the young person directly, and to treat the young person as being responsible and capable of making at least some of the decisions. And also, the therapist or the clinician has to be, they need not fake their identity. So be themselves, and uh, and don't have to fake any identity, don't have to put up any kind of thing, uh, any acting kind of thing. So empathic and non-judgmental attitude is something very important. Active listening is very important, creating a supportive space, and establishing confidentiality and limits of confidentiality. So these limits are related to self-harm, danger to others, etc. And we need to be very clear in the initial sessions itself about that. And whenever the adolescent is mentioning certain things, if we are not understanding, better to clarify then and there itself. And also when the adolescent is expressing any emotions, that emotional identification. So clearly making the statements that identify the emotions, and empathizing with the adolescent becomes very important. So we should not hurry through things, and we should not try to understand the young person very quickly. Right in the first session itself, we should not say that I've understood everything about you. So it's a very straightforward thing. I know the diagnosis. I know what problems you are going through. One should not make these kind of statements in the initial session. And if you do not know what they're talking about, it's better to clarify, ask, rather than assuming that you know everything. And if genuinely, if there is a question for which you don't know an answer, better to admit and tell them how you will find out about that. And especially sensitive topics that require, um, building of good rapport, and also exploring these kind of topics in a very sensitive manner, uh, and without being judgmental. So that requires preparation. So we need to be present focused, and also we need to be problem oriented. We need to this whole consultation process, it has to provide the education to the adolescent as well as to the caregivers, and we need to be very responsive, and we should not take a controlling or authoritative kind of authoritarian position. So some of the challenges include that the stigma. So both sides the stigma can manifest, and there could be the ambivalence for direct discussion, and the denial and avoidance also very common, and expressions of hopelessness, and so coercion also. Coercion, if is seen, we have to acknowledge, and if outright refusal for treatment, we have to make some safety plans. So some of the common mistakes that we do during consultation is not allowing enough time. conducting these kind of sessions in a non-private space, controlling the discussion, and trying to judge the adolescent and preaching to the adolescent, labeling and giving premature advice or reassurance, and interrogative kind of questions and encouraging dependence. So finally, the key components of the evaluation and management whenever we work with adolescents in the mental health settings are multidisciplinary approach, because that's something very important in this particular discipline itself, in child and adolescent psychiatry itself, wherein uh, the role of a psychiatrist, the role of a clinical psychologist, the role of a psychiatric social worker, psychiatric nurse, the role of a special educator. So multiple people need to be involved during the evaluation and also the management, and the relevant inputs have to be provided by all the specialists. And collaborative approach is needed with the adolescents and family, and the collaboration starts right from the first session itself. And family members have to be engaged as co-therapists, and the adequate number of sessions have to be provided for the family also, to ensure that they learn things and they are well educated and they have the uh, support constantly from the therapy team, so that they are able to assist and support the adolescent through the therapy process. And also, it's very important to liaise with the different systems. So, in case of adolescents who are attending schools and colleges, so it's very important to liaise with the teachers. Adolescents who are staying in the childcare institutions, either government run or the NGO run childcare institutions, it's very important to liaise with the childcare institution staff regularly. And also, adolescents who are referred from the child protective services like Child Welfare Committee or Juvenile Justice Board, it's very important to have a good liaison with those systems also. Uh, and whenever we are assessing this age group, what we need to remember is that all the tools that we use for adults will not be appropriate for the adolescent age group. So we need to choose and you know, use developmentally appropriate assessment tools. Uh, Very few validated assessment tools are available, in the Indian context. So whatever is available, we should be using in the assessment. Insight facilitation is very important, and whenever we use interventions, we have to go for evidence-based interventions, whether it's the medication interventions or the psychotherapeutic interventions. Family psychotic and family intervention play a very important role, irrespective of the diagnosis of the adolescent. And also, prompt referrals have to be made for the effective management of the mental health problems. So, I would like to end this session by giving these important messages, that adolescence is a crucial transition phase in the life of individual, and it's not just a period of turmoil. It's also a period of opportunities. Though there are certain challenges, that definitely the adolescent has a lot of opportunities to learn things, network, and be productive and become a healthy adult over a period of time. And contextual factors, they play a very important role in the adolescent development. Mental health problems are common during this period, and investment in the adolescent development and mental health leads to successful adult outcomes. So with this, I end my presentation, and thank you, and I hand over this to the organizers.
Thank you very much for the very lucid presentation, sir. We now open the Q&A session. We request the participants to post your questions or ask directly, to unmute yourself and ask directly to sir.
Sir? Hello?
Yes,
Yes.
Dr. Sabita, yeah, please go ahead.
Yes, sir. The thing is, now we feel there is a generation gap, sir. Even
Yeah,
with the therapists, they feel what they call generation Gen X or the Gen Z, if they come, they
yeah,
think what and all they say that has to be accepted.
Yeah.
If you want to say no, they are not ready to accept it. Even moral wise, culture wise,
Yeah.
if you tell them something, sir, they say no. Because why can't we do it? It is the main because of the westernization, and whether the aggression is being turned towards like it is being sexually active, even in girls as well as in males. I'm seeing, sir, earlier, and
Yeah.
also addiction, behavioral addiction,
Yeah.
and even other forms of addiction. And they say, why
Yes.
not? You are in that gen, ma'am. That's why you are telling this and all you are not supposed to do. What is the problem? Even if you explain about HIV, pregnancy, or so many things, sir, they are not ready to accept. Have you felt like this in your consultation also? Because we are in the last or a few, that is 1 year or something like that, the same thing comes. Okay, right? They say it's generation gap. You belong to that generation. We belong to this. So you don't understand us. Like that of comments that comes, sir.
Yes. Thank you, madam. Thank you for that valuable input. So yes, we do come across adolescents, especially that's why that one slide I had put wherein the Gen Z and Gen Alpha,
Yes.
it is adolescents who are this very young generation, young people, like wherein they see their parents, caregivers, professionals, irrespective of their specialty, whether it's pediatricians, psychiatrists, psychologists, whoever it is, as from the older generation, and they don't know about the current trends or current things, and so they feel that we are just just preaching certain things without understanding current trends or current what people are doing, and they also feel that there is nothing wrong in doing these kind of things. So I think what is important is it's as mental health practitioners in the current generation, when we work with the children and adolescents, we need to be very much aware of these kind of trends. We need to be very much aware of their perspectives or their thinking. But at the same time, when it comes to evaluation of their mental health, so I think it has to be. So one need not be go with a very judgmental or very preaching kind of mode, but at the same time, one needs to definitely, if we see that, say for example, very clear risk-taking behavior, it's our duty to tell the and that is where, like, when the risk to self and risk to others is there, and discuss with them, and that confidentiality limit has to be explained, and bring in the family members also and discuss with them, and more importantly, like, document the things. That becomes very important, because we see that like in the other specialties, even in psychiatry also, of late, like, litigations have been increasing. So it's very important in consultations to properly document, like, what has been discussed, and of course the confidentiality of the documents has to be maintained, but at the same time, one needs to provide this kind of standard of care.
Yes, sir. Thank you, sir. Thank you. This is all we
Thank
face,
you.
sir, during these
Yeah.
times. And if they have
Yes.
a failure, also they say they want to kill that girl or boy, sir. That also is
Yeah.
happening.
Yes.
Whether we have to disclose it or not, because I am facing it for the past or 15 days like that, sir.
Yeah.
They
So
they are coming and that is allowed to that is there is a love failure allowed to kill.
yes,
That's
and
what.
in fact,
But otherwise,
in
coming.
fact, madam, actually, we keep reading in the media about also these kind of incidents across India,
Yes.
wherein very I think violent acts being committed, uh, like by adolescents as well as young adults, wherein, like, I think whenever they're expressing that clearly, I think that needs to be, that's where the confidentiality limit has to be stated, and the
Yes.
parents have to be informed, saying that, because we don't want that adolescent to end up harming himself or someone else.
Yes, sir.
So yeah, and sometimes
Thank
we that is probably, like, there will be multiple factors, like, as I mentioned, the contextual factors, the family factors we need to explore, and also the peer group. Like, sometimes we see that they are getting into the deviant peer groups and correct doing these kind of activities, and also sometimes the parents themselves, they don't have the regular supervision and monitoring of the adolescents, and they, by the time they get to know of these things also, it's quite late. By the time they seek help also, it may be late. Yeah, that early identification doesn't happen. So I see that one Dr. Maria Antony has a question. I think she raised the hand. So please unmute yourself and ask the question.
Hello, can you hear me, sir?
Yes, yes, please go ahead.
Sir, as a experienced of late, I have been seeing adolescents being brought to the clinic by parents for
Yeah.
antisocial behavior, not very
Yeah.
not social, but to antisocial behavior towards the parents. And usually they are brought to the hospital without, to the clinic without their consent or assent. Now, how do we go about with such adolescents? Because the adolescent is not willing to listen to us. They have been brought there by force, and if and the parents come with a lot of expectations because they want some sort of respite. And it's not a medical condition where I can just give them medications and get the child better. So, how do we go about in these kind of tricky situations?
So it's a very good question. Like we come across these kind of instances commonly. So uh, these are behavioral disturbances which they may not be very violent kind of aggression, especially happening in the community kind of context. But one thing we very commonly see in our clinical settings also is that this is mostly in the home context, wherein they behave aggressively towards the parents, and there is a lot of demanding behavior, and they are quite stubborn and very uncooperative with the parents. So that impacts their day-to-day functioning also, and they are very reluctant to come for the evaluation. So typically, no, the rapport building itself with these adolescents takes time. So it's not that easy. So uh, over a period of 2, 3 sessions, slowly that rapport is built, and we need to clearly establish a context for us providing any support. Otherwise, the adolescent will say that, yeah, my parents have just brought me here, and I don't have any problems. Why should I be talking to you? Like, no, I have. No, simply one or the other person keeps advising me. Like my parents keep advising, my relatives keep advising, my neighbors keep advising, and you are the next person like who is advising. So they are not willing to talk about their issues. So that has to be changed, and they should accept and identify. Like say for example, typically when we uh, do that in a very non-judgmental way over 2 or 3 sessions, slowly they'll accept that yes, anger is a problem. Then they are willing to work on that also. And we need to, oftentimes we see that in these scenarios, that there is a lot of blame put on the adolescent because the parents and others, they say that you are the problem. So you have to be fixed. So rather than that, we take this particular model where we explain the possibility, explore the possibility of all the contextual factors, including the family factors, and then say that, yeah, we are going to work, at all these levels. It's not just you being the problem. It's probably some kind of vulnerability in you, but at the same time, the other factors might have, pushed you to this level where you have developed this kind of certain problems with your behavior, and explain to the adolescent and working with them.
So usually it
So
doesn't go to the second session, so they don't come back after the first one. So then in
yes.
that one session, it's
Yeah,
difficult to.
one session is difficult, and for those people who are able to come for at least a few sessions, maybe 8 to 10 sessions or something like that over a period of time, we can. It will take time for us to see any meaningful kind of changes in the behavior,
So in the
because
meantime, we can probably just see the
sometimes
parents.
sometimes parents also expect, like sometimes parents may have a very unrealistic kind of expectations. They may come and say that, no, you just give some medication and he should be all right, within the
Yes,
next
sir.
one
That
1 week. So that doesn't change like that. Like especially for these behaviors like conduct disorder and all those things, it's not like, say for example, an acute mania or acute psychosis kind of thing, where immediately after you put risperidone or some medication, the
yes,
person
sir.
will become all right. So it takes time. The behavioral disorders are definitely for the change to come across. So we need to tell the parents that minimum, like especially when we do the assessments and no, the psychologist starts the behavioral intervention. The minimum time that is required is at least 2 to 3 months of intense behavioral intervention. Any changes can be expected. So before that, if they say that no, this is not changing, and typically they engage in what we call the doctor shopping also. So they may go to one psychiatrist or psychologist in their place, then immediately they'll go to another city or another in the same city also different people. Like that, they visit multiple people, and finally they give up, saying that things are not changing. We see that sometimes within you know uh, a short time itself they give up, like saying that within a month they say that yeah, this fellow is not going to change. Simply let us not waste time, kind of thing. Uh, and also, I mentioned about comorbidities. It's very important to, in the thorough evaluation, to assess all possibilities. Like sometimes even we have come across some of the medical conditions also presenting, especially neurological conditions presenting with these kind of acute behavioral issues. So we need to evaluate and rule out those conditions as well. So there are a couple of questions in the
Thank you, sir.
yeah, thank you. A couple of questions in the chat box, and we'll just read that. So first thing is that how to deal with adolescents who have dissociation. It is difficult to treat in clinical setting. Your opinions? Okay, so the dissociative disorders or even the presence of dissociative symptoms in conditions like depression, anxiety disorders are quite common in terms of presentation. So it is not an uncommon thing to see. And it's very important to immediately not jump and give a uh, decision saying that this is just some kind of psychological or psychiatric condition. So thorough evaluation is required, and relevant investigations and referrals have to be done. Say, for example, one of the most common presentations is dissociative spells of unresponsiveness, where suddenly the adolescent fall down and sometimes may have the limb movements or any posturing. It may appear like seizures, and wherein definitely we need to have a good liaison with the neurologist, pediatric neurologist, where we refer to them and we discuss with them, and they actually are familiar with these kind of presentations, and then they do the relevant investigations. And when the investigations are done, also to discuss in such a way that make them understand that stress sometimes affects the functional aspects of the brain, and that functional aspects, when it gets altered, it can result in these symptoms. So that's a good explanation to give, rather than, like, suppose you get some investigations like EEG, MRI, etc., and they may say that okay, no significant findings are found, but how come my no son or daughter is having these kind of symptoms? So we should say that yeah, it is more of the functional aspects that are impaired the brain, and that's why we are having these kind of symptoms. And it requires building good rapport with the adolescent, and we should aim at gradual improvement in functioning. We also see that some families, they become very anxious. They just get into this, doctor shopping kind of thing, which I mentioned earlier. So we should ask them to resist that and just stick on to the treatment, and slow improvement definitely will happen, especially in adolescents with the dissociative symptoms. There is likely to be good outcomes, especially when we immediately evaluate and manage the symptoms. So next question is about uh, the trauma-informed approaches in dealing with adolescents. Yes, there are specific psychotherapeutic approaches uh, in adolescents who have this kind of adverse childhood experiences, wherein these are quite traumatic, and to understand the process of evaluation, even the certain assessment that has to be used in them, and also the therapies, like say, for example, trauma-focused cognitive behavior therapy. So overall, it is called trauma-informed kind of care, and that needs to be provided to these adolescents. So the next question is, are there any tools that will assess whether the adolescent has attained the adult level of thinking or decision making? Because at times we get cases referred from judiciary to assess this when it comes to in conflict with law. So here clearly you need to mention, when such cases come, there are two instances. One is the adolescents who are in the 16 to 18-year age group, who are alleged to have committed heinous offenses. A heinous offense in the Indian criminal justice system is something which carries a punishment of 7 years or more. So the adolescents who are alleged to have committed these heinous offenses in the 16 to 18-year age group, they are referred for what we call as preliminary assessment. So there is a standard methodology for doing that preliminary assessment, and at NIMHANS we have developed assessment methodology. So I would be happy to share with you later about that methodology. But in other cases where this they are committed some petty offenses, these are not heinous offenses, they may be referred, and wherein if there is any concern that is expressed saying that whether what is their understanding about that particular offense and all those things. So we should focus mainly, if the development assessment that is required, we need to get that done by the psychologist, and also we need to rule out any mental health conditions. But we should not, uh, give too many details about this, case, like exactly whether they have that understanding of the case and all those things. So that limited information itself will be required. The next is the poor tolerance, high impulsive and hypersensitive. Many college-going students also found the self-harm cases are raising so much. Relationship starts at 6. Okay. Yes. So these, like sometimes we see that the poor tolerance, high impulsivity, etc., may be uh, part of their what we call their temperament in adolescence, and sometimes it may be related to certain disorders. Like say, for example, if they have ADHD, definitely the high levels of impulsivity is definitely to be expected. And so the engage, like the being very sensitive to the whatever they experience, sensitivity to criticism or sensitivity to some of the even stress that happens regularly, like that is part of the temperamental characteristic. And we see that yes, the self-harm also, there is a worrying trend where no increasing kind of instance like getting reported, because one possible reason is that the contextual factors contributing to that directly, and also the increasing awareness like about these cases, and more getting things getting reported through media and other forums. So then there is a question from Dr. Mridula Pradeep from Coimbatore. I would like to know your thoughts on navigating the use of screens and gaming. While other countries are creating bans on minimal age for social media, our children are increasingly falling prey. Is there any room for prevention? Where should we start? With parents, students, or schools? What's your advice? So, to the parents of adults. So, as far as this, no, the gadget use is concerned, or technology use, and whether it's for gaming or other purposes, first and foremost, the advice for the parents is that they should monitor their use. They should be good role models, and also, you know, uh, from the beginning, they should inculcate some kind of non-gadget activity also, along with a little bit of gadget time. So it is not possible to achieve the complete zero gadget time for any adolescent. It is impossible. It may be idealistic, but it's impossible. All this banning of things. So suppose one particular thing is banned, the other thing will come up. So it's not practical. But at same time, there are adolescents where clearly it goes up to the level of what we call a behavioral addiction and clearly impairs their function. That's when immediately the help has to be sought. So next thing is adolescents with attachment issues have trouble during adolescence. Can attachment be repaired? If so, how? Yes, this is a very important question. Yes, these attachment issues can be long-standing attachment issues right from the early childhood itself. In therapy, actually, when we engage in individual psychotherapy with adolescents, we need to evaluate these aspects, and especially when we look at their family environment and the adolescent's attachment right from the early childhood with the primary caregiver, that is usually the mother, and the other family members, the other parent, that is the father, and also the siblings, etc. And sometimes it could be an alternate care provider, like it could be a grandparent or uncle, aunt, etc. So sometimes with the this kind of disturbed attachment with them uh, may cause a significant negative impact on their development as well as their mental health. yes, it needs to be addressed in therapy sessions at a later point of time whenever the adolescent presents with, it can be with significant anxiety kind of symptoms or depression, or it could be presentation as a dissociation or any form of emotional or behavioral problems that needs to be addressed through individual psychotherapy sessions. So those were some of the questions in the chat box. If there are any other questions, please feel free to unmute yourself and ask the question. Or you can also share any of questions only. You can share any of your experiences working with adolescents, any of your recent kind of insights when you work with adolescents.
So, sir, what are the specific parenting strategies that we can empower parents of Gen Z adolescents? Any
Okay.
specific? We usually empower with authoritative parenting strategies. Any other specific strategies for Gen Z adolescents, sir?
Yeah, so I think what is important for the parents is to properly educate them about the current generation, like the Gen Z and Gen Alpha. And so saying that they definitely, their exposure to the digital world and also their awareness about different things, their likely peer interaction with a very wide or broad group of peers, both offline and online, and their quick learning about different things. So all these things actually the parents have to be educated, and also parents, whenever they communicate, they have to be very careful, like how they communicate and how encouraging that open, honest kind of communication is very important. And also not assuming that they know everything, but willing to uh, mutually learn from the adolescent, and also to guide them properly, supervise properly. And it's I would not say it is easy, like definitely parenting in itself is a difficult thing irrespective of the age group, like right from the infancy itself, there are challenges, infants, toddlers, and as they grow into the adolescence, and beyond that, once they become adults, through these life cycle stages, actually parents face a lot of challenges, and especially with this current generation that has become much more.
Thank you, sir. Sir, many times also my second question is, many times when we try to collaborate with schools, like educate the school regarding the adolescent condition by either giving letters or informing the school about child's condition, schools are dismissive of the child's condition. How do we help the adolescent when the school is dismissive and not supportive of the child's condition? Many times we are left out with the only option of changing the schools. The school is not supportive.
Yeah, so I think this is also a very important question. So as mental health professionals, right from the time of that consultation, so what we do at our center is that so during the initial visit itself, we ask for of course, with the consent of parents, we ask for a feedback from the class teacher, like about the child's behavior in the classroom, child's learning in the classroom, etc. And from that time, the contact with the school system starts. And we have had this kind of mixed kind of responses. So not every time we are successful in establishing that kind of good meaningful kind of interaction with the school. And sometimes whatever attempts we make, the school may not understand and support the child, and specific requirements are communicated uh, through writing letters or sending emails. We see that the response is not that adequate, and in fact that stresses the adolescent as well as the parent very much. And also this option of changing schools repeatedly also is quite stressful for the adolescent, because the adolescent has to adjust every time to a new environment. So it's a very I would say a difficult thing, especially when the schools they are not under schools or colleges, they don't understand and they don't provide that mental health support. Of course, with the recent kind of changes, you may be aware that especially with regards to the current scenario that is happening in the country, wherein the Honorable Supreme Court has taken notice of, especially the self-harm kind of incidents, and given the notice to the union government as well as all the state governments, and a committee has been formed at national level, and there is a lot of discussion, and of course post-COVID also a lot of discussion that had happened about mental health in the country, and especially mental health of young people. So there are some changes that are happening on the ground, and definitely there are a lot of, we see that especially over the last 5, 6 years, a lot of NGOs also in the community actively working in the area of mental health of young people. So, I would say that there is some hope. Definitely things will change. There are difficult scenarios or situations, but we should not lose hope. We should continue, should put in our efforts as mental health professionals.
Definitely, sir. Thank you, sir.
Can I offer few words, sir?
Yes, ma'am. Thank you. Yeah, go ahead.
I am Dr. Geetanjali, sir, Professor of Psychiatry, Madurai Medical College. Sir, of late I see current generation, Gen Z's parents or Generation X, they are feeling that they didn't enjoy certain things in their life, so let their children enjoy. So in that
Okay.
attitude, they have become permissive parents. So what happened? They are very affectionate, caring. They are trying to get whatever they want for the child, give the cell phone, give all the gadgets. But when they come to adolescence, the children grow and become to adolescence, they are facing all sort of behavioral problems. They didn't know how to manage the adolescence. The limit setting is not happening.
Yes.
Other parents should be educated more about the limit setting during the primary years itself, and the less than 10
Yes.
years itself. The parents become so confused how to bring up these children, and adolescents, when all the problems emerge, they didn't know what to do because they didn't evolve themselves as parents who are little bit directive or limit setting or trying to guide the child or shaping up the child. Those things they didn't do. And moreover, current parents are going to job, both of them going to job. They are just spending little amount of time. In that little amount of time, they want to satisfy their children as much as possible by means of permitting them, taking them outing, or getting them whatever they are want. So they are trying to bargain in this way, and they avoid limit setting. That has led to all these problems. And one mother is telling, when the child expressed that I like that girl, I am talking with that girl by 12 to 13 years of age, that mother is telling that is expected in this generation. So I felt that is okay. Now her son has become so impulsive, self-injurious. In 10th standard, is not going to job because of relationship issues with that girl. She didn't know what to do. So the parents also should be educated and given importance. And the current the children are not able to get any direction, self-limiting, and want to enjoy everything, but at the same time they are very much dissatisfied. The parents are also part of the problem, I feel, sir, not only the adults.
Yes, I think a very relevant thing you have mentioned, madam. Like parents are very much part of the problem, and in fact, we see that this trend, what you mentioned, like wherein the permissive style of parenting that starts, no, in the childhood itself, and I have come across many parents wherein they start off with the permissive thing in the childhood and try to suddenly change it during the adolescence period, which is not possible. Like, from the beginning, they have been providing all those things, and especially like where they are not able to spend quality time, and their permissive kind of thing is that we just give something to the child, so I'll get something for the child, I'll buy something or some, usually the material kind of reinforcements, what we call
Yes.
buying some gadgets or buying some very expensive things. In fact, I vividly remember one adolescent who had come from Tamil Nadu. This was pre-COVID consultation, wherein the parent had a single parent actually, wherein so after the unfortunate demise of the father, like mother had been very permissive, and the boy grew up and he was an adolescent at that time. And she, in the history, she mentioned that, sir, he's been asking for a lot of cars. And I thought like it would be the car toys, like say, for example, this remote control cars or this kind of things. I said, like, then she said some three, four we had bought and kind of thing. Then I was shocked to know that actually it is the real cars. And so it is, mother had bought two, three brands of vehicles after making some loans because child became so demanding. He wanted to go in one particular car, the other car at different times to school, tuition, etc. And she has been quite permissive, brought all that, and it has reached a level where he started threatening her, like saying that if you don't give this, I'm not going to go to school. I'll not do homework or something like that.
The purchase
So
is playing the spoil sport too much, I think, sir.
yes, and also what happens is like now with the digital thing, that is also a challenge, because everything they are seeing on internet or TV, like wherein uh, things can be purchased. Like say for example, you can just order something online and it will come within a day sometimes or maximum within a week. And at the click of button, you can order the most expensive kind of food or gadgets or anything like that, and they see that. And the COVID pandemic also was one really challenging period as far as the parents and children are concerned, wherein like though the exposure to gadgets had peaked during that time, and especially say for example, you know, uh, ordering for food outside or ordering for some of the gadgets or other very expensive things, the branded items. And also there is a lot of another factor that comes up here is especially for children, who are like certain children, I'm not saying all children, certain children who are from the upper socioeconomic strata. So they may afford certain things like suppose branded things and they may just show off in front of the children uh, who are from the middle socioeconomic status. And those middle socioeconomic status children, they pressure their parents saying that I want those branded things only, which my peer group are using. Like, if you just buy the ordinary pair of shoes, they don't like it has to be some, uh, multinational company or some international brand kind of thing. That expensive. So every time parent ends up spending thousands of rupees in addition to the expenses that is there for education. Like, education also has become so expensive. We have seen lakhs of rupees they are spending for that. So it becomes very burdensome, and so parents are severely stressed because of this. So there is also a couple of other questions I will quickly take. So there is this question
Sir, can,
about our,
sir, can
yeah,
NIMHANS suggest the government like banning using mobile phones till 12 years of age, as in Australia or Korea, they have planned there? Can NIMHANS suggest banning mobile phone use till 12 years of age?
yeah. So NIM, so like I can't, talk on behalf of NIMHANS right now. So I'm just a faculty at NIMHANS. So the government as of now, no, has not taken any such decision. Um we don't know because certain, as you mentioned, like countries like Australia and all have banned outright for below 13 years and or below 12 years, and certain other countries have imposed regulations with regards to the gadget use. Uh, we also should have some kind of reasonable regulations. If in a large country like ours, when we talk about these bans, look, say for example, with regards to gaming, we had seen some time back that PUBG was banned. So
சும்மா அது
af,
பேசுறது.
after PUBG was banned, some other thing came up like that, the alternate. So how we are going to implement these things also becomes important. So then there is a question about adolescent with OCD, how we are going to get support from school. Definitely, I think an adolescent with OCD, we have to just look at the symptoms and how symptoms are causing impairment in the school context that we need to see, and what kind of support will the child require. Like say, for example, if child has obsessions related to contamination, every time he's in the classroom, so he touches some table or touches a book, he may feel that his hands are contaminated. He may just ask the teacher, I want to go out and wash my hands and come back. So those kind of things teacher may find very strange, and in fact teachers may punish the children like having this kind of problems. So with the consent of parents, I think it's a good idea to interact with the teacher, like through a phone call or a video call and just explain to them that these are the kind of symptoms, and child has to be supported. Child is not deliberately doing anything or acting, etc. Then there is a question: do you find that behavioral problems related to pornography is normalized in the group of many who seek help? Is this a cultural change that is also seen in this clinical context also? So, yes, to some extent, it's right. And however, like one of the concerns is that, as I mentioned, the access, unlimited access of to things over internet, like sometimes they get exposed to this inappropriate kind of content also. And there is a very high chance, because we have seen across social media where some of the adults themselves are faking as adolescents, and then they get into these virtual relationships, and then there is this chance of online exploitation of these adolescents, and a lot of those scenarios also we are coming across. And with the advent of the artificial intelligence and other very new kind of technological things, it's quite scary actually. And all of us, we keep reading in the media about all the deep fake videos and morphing and all those things. And artificial intelligence, with artificial intelligence, it has gone to a totally different level altogether. With youngsters, without much understanding about this, may just become victims of these kind of problems.
Thank you very much, sir. Over to
Thank you.
Dr. Raman for the vote of thanks.
So thank you so much, sir, for that wonderful comprehensive presentation and taking us through the journey of development of adolescence through various theories. I just had a just doubt that it's like how the biological age of maturity has been actually preponed.
Yeah.
Like people as students, they attain menarche at a very early age. So I think the
Yeah.
developmental trajectory is that a change, whether they actually take place through the adolescence or there is going to be actually a preponement of the age. Because like now there is whether they really actually follow through the cognitive Piaget stage or the
Yes.
developmental trajectory. Will there be a
So,
change? Is something I was just wondering, sir.
yes, and that is a very good question. Actually, what I feel is more research is required in this area. And because we see that with all these rapid kind of changes that are happening, and we are seeing in the current generation, Gen Z or Gen Alpha, etc., wherein the kind of exposure is too much for them, and even the physically also we can see that the changes happen much early. Um, and even the behavioral changes are also quite, I think, quite early kind of behavioral changes, and even the things like risk taking, these things also very prominently we are seeing. Aggression also is quite increasing. So, though these theories were given at a particular period of time earlier historically, and we need to rethink, and we need to specifically when we apply these theories in the current context, definitely there are going to be limitations that all of us we have to accept, and these theories were probably conceptualized at a particular period in time, though most of the theoretical concepts, no, they are relevant, but at the same time, when it comes to the practical application, we are seeing the challenges. And so my opinion is more research has to be done especially in the current generation of adolescents, and how this play out actually, like, say, for example, with all these variations, how much it is applicable.
Sure, sir. Thank you so much, sir. The other concerns that we also face is the emerging personality traits, evolving
Yes.
personality traits. I think previously we used to actually make this diagnosis in ICD-10 very
Yeah.
rarely. But now I think the ICD-11 has come with the dimensions of the personality traits, which we might be actually forced to use that as one
Yes.
of the thought process I
And
was actually
we are
having.
seeing that more frequently nowadays, wherein especially right from 14, 15 years age onwards, some of these behavioral patterns clearly pointing towards the personality kind of changes.
Yes, sir. Which
Wherein
used to be not there before. Yes, sir.
though most of us we hesitate to make a diagnosis of personality disorders at that point of time, like whether it's a emotional unstable personality or whatever the conditions, but it is quite obvious actually that these traits are quite well established. These are quite obvious. Just it's a matter of time, and for them to manifest that disorder level kind of problems.
Sure, sir. Sure, sir. So thank you so much, sir, for that wonderful presentation and being there for the answering all the queries very patiently. I
Yeah.
sincerely thank President of Tamil Nadu Chapter IPS and all the executive members, Dr. Arun Kumar sir, and all the members of the Tamil Nadu Chapter who helped through making through this child psychiatry webinar series. And I'd like to thank place on record special thanks to Dr. Shainika, who is actually steering this topics, choosing the speaker, and ensuring that like things go on the platform. And thank you so much for all the August audience who were actually present and interacted throughout the session. So thank you so much, sir. We look forward to another session in the next month. And we will be actually in touch to actually share our mutual experiences and clinical knowledge. Thank you so much, sir.
Thank you very much, Dr. Raman, and thanks to IPS Tamil Nadu chapter, all the office bearers, and special thanks to the scientific committee and also Dr. Shainika to have wonderfully coordinated this whole event. And it has been a great learning experience interacting with all the participants today. Thank you, one and all, and have a nice weekend. Thank you.
Thank you very much, sir. Thank you, sir.